Hello, I'm David Cohen from the Mid-America Heart Institute in Kansas City, and I'm here, Seoul, Korea, TCTAP Pacific, discussing a roundtable about bioabsorbable vascular scaffolds. I have an esteemed panel: Adnan Kastrati from Germany, Ashok Seth from India, Yeung, my former cardiology fellow from a long time ago back in Boston, now from Stanford. So I won't contradict you too much, Alan, from that. But it's certainly our pleasure to be here and talking about a very interesting and perhaps controversial topic, the issue of bioabsorbable vascular scaffolds. And I can't seem to get the slides to advance, unless I'm going the wrong way. There we go. Okay. So we're going to cover efficacy and safety data, talk about some of the early trials, and then probably the concerns that have come up over the last year or so from the Absorb 2, talk about the PSP technique and the data that support it, and some data that just were recently presented at the most recent ACC meetings, and then talk about where this whole field is going. These are among the clinical trials, the evidence base to date about BRS. There are a number of studies, some of them industry-sponsored, some of them non-sponsored, some of them registries, some of them randomized trials. And in general, what these studies have shown is that the early outcomes of BVS, at least in any individual study, seem to be comparable to the current generation drug-eluting stents. But there have been, even at the very early stage, there were always some concerns. So these are data from the Absorb series of trials, Absorb 2, 3, Japan and China, a pooled analysis of those that was published last year by Greg Stone in The Lancet, showing, although not quite statistically significant, a doubling of the risk of device thrombosis within the first year, which certainly has been of concern and has been seen in other studies as well. So this is one of the first early concerns about early thrombotic events. But what has been equally concerning, I would say, and perhaps even more concerning, has been some of the later events. So at the most recent TCT meeting last fall, the 3-year results from the Absorb 2 randomized trial, about a 500-patient randomized trial, were presented, and shown on the left-hand side here is the device-oriented composite, basically target lesion failure, which was doubled with the Absorb platform compared to the Xience. The patient-oriented composite is less sensitive to stent-related differences and was not different. But one of the interesting things about the device-oriented composite was there was the early excess related to thrombotic complications, but then there was also a late excess related to MI and stent thrombosis. And you can see that here. These are the scaffold or stent thrombosis rates at 3 years in Absorb 2. And you can see that the definite thrombosis was 1.8% with Absorb versus 0 with Xience, and the same thing with definite or probable. So again, a significant, or not as statistically significant, but certainly a concerning trend. When the scaffold is supposed to be resorbing, it's still having late events. And so as one of the things that has come out of this experience has been this concept of using the proper implantation technique, and the acronym that the Abbott has come up with is PSP, P for prepare the lesion, S for sizing the lesion optimally, and then P again for post-dilating. And this is the technique that we've all been trained on subsequent to the trials. The problem is that most of the trials that have been conducted to date did not use this technique. It wasn't appreciated, perhaps, the importance of it. One of the few studies that suggests that this technique is actually beneficial, because again it hasn't really been formally studied, is the MyCat registry, where patients were segregated according to whether they used the Absorb-specific PSP protocol versus a less specific, more generic implantation protocol, and there was a significant difference in scaffold thrombosis associated with the BVS-specific protocol. Most recently, we have started to see data now from the United States. These are data from the Absorb 3 randomized trial, about 2,000 patients comparing the Absorb scaffold versus the Xience cobalt chromium everolimus stent. You can see target lesion failure between 1 and 2 years continued to trend slightly higher with the Absorb platform, and even in the larger reference vessels, which was a concern. The small reference vessels were problematic early, but the large reference vessels were not immune to a slight excess of late events in the Absorb 3 trial. if one looks again specifically at what endpoints there were, one can see in the overall population a small excess of target vessel MI, a small excess of definite or probable stent thrombosis, and even if one looks again at the reasonable sized vessels where the QCA is greater than 2.25 millimeters, again, there is still this small trend towards excess late events in the absorbed scaffold. When one looks at the specific cases, these very late thrombosis events, these thrombosis events that occur beyond 1 year, what one can see very clearly here, if you look at the line that says PSP, is that not one of those patients had received the optimal scaffold delivery protocol. In addition, the interesting thing is that these events did still occur on DAPT. I've seen this slide two different ways. I've seen it with one of the patients being on aspirin alone. I've also seen it with two of the patients being on aspirin alone. So I'm not sure which of those is more correct. But the PSP data, none of the patients had received PSP. Now, one of the challenges in studying PSP in Absorb is that nobody got it. These are data that were presented by Steve Ellis and Greg Stone, again, at the most recent ACC meeting and the CRT meeting. And if one looks at the green line here, these are the patients who received the Absorb scaffold and received it with the PSP technique, and one can see that the results there are more comparable to what was seen with the Xience, both with respect to target lesion failure as well as stent thrombosis, but there were only 95 patients who received that. It was not appreciated at the time. But I think to try to at least allay the concerns about the scaffold, the Absorb investigators did a very interesting thing and presented blinded pooled data from Absorb 4. So Absorb 4 is the most recent trial, almost completed enrollment in the United States, the largest trial to date, really comparing Absorb versus the Xience scaffold. And here they pooled the data. The PSP technique was used. You can see the post-dilation in Absorb 4 on the right-hand side was used in 84% of patients. And what one can see if you look at the Absorb 3 pooled on the left and Absorb 4 pooled on the right is that there were significant reductions in scaffold thrombosis from 30 days, both at 30 days and at 1 year. Now, we don't know what's driving this. We don't know if this is just the Xience stents doing really, really well, or if this is an improvement in the outcomes in the Absorb group, but it is at least somewhat suggestive that things are getting better with the Absorb scaffold, but only time will tell when we actually have the results. Now, on the same day at the ACC, when the 2-year results from Absorb 3 were released, because of pooled data from Absorb 2, from Absorb 3, and other studies, the FDA in the United States issued a warning letter, not a recall. The scaffold is still available in the United States, but a warning letter that basically says that physicians should follow the package insert. When the package insert basically says use the PSP technique, make sure to choose adequately sized vessels, don't treat patients with smaller than 2.5 millimeter arteries, but it is out there. It's part of our landscape. If you're going to be using these days in the United States an Absorb scaffold, you probably need to be aware of this and to go over this with your patients at the time when you use it, explain to them why you're doing it. So that's kind of the data, that's the background. Sorry for talking so quickly, but I wanted to save some time for us to talk. And so here's the things that we are going to be discussing over the next 20 minutes or so. Really just what are the realities of BRS today? What should we expect from this device? Where should we be thinking about using it? Should we be thinking about using it? What should we look for in the next generation devices? Again, I'm going to look to some of our European colleagues who have more experience with these devices and our Asian colleagues for that. And then obviously, how can we use this device today, which again has some very desirable and interesting properties? Can we use it in a safe way for our patients? So let me start just by talking about your overall impressions of the data. There's been a lot that's made of the data, a lot of concerns, a lot of wringing of hands and all sorts of things, and I think all of you have been involved with this device at some phase, have used it, I'm sure. So let's just start. We'll start down this end with Adnan, and tell me. I mean, do these data worry you? The data we have so far with this device.
David, thank you for the opportunity to state my opinion about this issue here. I want to go back to the story of bioresorbable scaffolds. So you know that 2000 there was a publication from Igakitamai stent, which is the same material, the same almost the same strut thickness as Absorb now. There were 15 patients at the time, and only 6 months results published. This study was followed by 10-year follow-up study, 2012 in circulation with 50 patients. And what was evident from this analysis was restenosis rate was comparable to the bare metal stent. But there were no concerns about scaffold thrombosis. There were only 2 scaffold thrombosis, one subacute and one very late. So for the first experience, it's not too bad. So, and that's why it was very logical and obvious to go to next step, to put the drug on this device in order to reduce restenosis, as it was done for bare metal stents. And this story shows also how important are the numbers, because with 50 patients alone, you cannot evaluate rare events such as stent thrombosis. It was followed by very enthusiastic results by Absorb cohort A and B, no stent thrombosis at all there, and the restenosis rate was reduced as expected from putting the drug on the device, on the scaffold. And so we got the results, the real results regarding scaffold thrombosis only after having thousands of patients, only after having a little bit unselected patients, such as those included in larger trials, in AIDA trial ultimately. And I think that there were 2 concerns. One, for the early results, there was increase in the early scaffold thrombosis, which is for sure, which is manageable by the procedural technique. And I am very confident, and I have used also in my patients that, and also seen very good results. So you can avoid the early stent scaffold thrombosis by improving the technique. The most important concern is with the late, very late scaffold thrombosis, because I'm not so confident that using an optimized technique you can influence 10-year results. So I think that something has to do with the material itself there, and which should be resolved or should be improved with future technologies.
But it's, I mean, so you think we've already, overcome the early problems?
I think that it is reassuring, from my experience, at least in my center, that none of the patients who were on double antiplatelet therapy did have scaffold thrombosis. And all the cases, we had 6 cases having a scaffold thrombosis after the first year, all of them had stopped dual antiplatelet therapy. And this is very reassuring for those patients who have this device. So continuing the DAP,
okay.
You can avoid
and we'll come back to that a little bit. Yeah. So Ashok, you probably have the most experience using this device. I think you've been using it the longest and probably in the most patients. Tell us your experience and your thoughts.
So my thoughts around this are that it's physiologically logical and intuitively a very attractive device. Yes, the thought of not having a permanent implant forever in the life, especially when you need long stents, multiple stents over a period of time, treatment of coronary artery disease is a staged therapy over years. So it's a revolutionary therapy. And like all revolutionary therapies, we're learning more and more about it as time goes on with increased number of cases. The fact that it had a high acute and subacute thrombosis rates didn't surprise me. I was sort of knew that could happen because we go back to our first gen metallic stents, we go back to the thick stretch metallic stents and the first generation of drug-eluting stents, and we had those. And we knew that the counter of it was high pressure implantations, get as large lumen as possible, and more so with this device. So that is something which I'm very confident that we overcame very early on, and much of these studies which we now see were done in an arena when nobody thought that high pressure dilatations would be so important, but experience told us that it would be. It was just that there was a learning curve to it, to understanding this device. And I know that in the Absorb study, scaffolds are implanted at 10 and 12 atmospheres. perhaps because of the concern that high pressure may actually damage the scaffold.
That was what we were told at that
So,
stage.
so really, though the techniques which you used at that time are totally alien to the way we implant scaffolds, and I implanted scaffolds from the December of 2012, apart from the previous, that I was a part of the Absorb Extend, which was 2010 onwards. But we didn't use high pressure dilatation at that time, but by 2013 January, I was very clear about this high pressure dilatation, and high pressure meant non-compliant balloons going up to 22 atmospheres. So that was fine, and our own data supports this very fact that we have absolutely no acute or subacute scaffold thrombosis. Even our 1-year scaffold thrombosis rates at 0.3% are our combined data of the two centers, which is Dr. Colombo's and ours, is going to be presented at the EuroPCR this year for a 2-year follow-up on highly complex subgroup of patients, which is mean lesion length of approximately 3 centimeters and B2C lesions of 75%, with a 99% use of PSP, and our scaffold thrombosis rates being less than 0.5%.
So
At
we
2
can
years.
overcome it.
So that's an important aspect. However, I must caution the whole arena by the fact that this was unexpected. The late scaffold thrombosis rates, as appeared, were unexpected. We could actually understand why the acute scaffold thrombosis were there, and you'd see in all the data which is there. There's no doubt that these thick struts are thrombogenic, and that's not surprising either. But they were all acute, and well, majority of them were acute and subacute, so they were procedure related. This late business is truly a new animal. And I don't think that it's a very simplistic animal. I think we need to understand it better and further better. If you saw, we know that retrospective and contributory and circumstantial data tells us that PSP even helps to negate, or may help to negate, the late scaffold thrombosis. But I also believe that we just saw, even in the Absorb 3, the 4 patients who had, actually if you see the PSP, it was nil, but if you see the post-dilatation, all of them had post-dilatation. All of them had a 0.5 millimeter higher balloon for post-dilatation.
So pretty aggressive, yeah.
Yeah, and they had a 16 atmosphere post-dilatation with a non-compliant balloon, which was higher than the scaffold size. So there may be more to it than that. And I agree with Adnan that I think the dual antiplatelet therapy has to be, it's a multifactorial etiology. A part of it relates to partially or under-deployed scaffolds which are hanging there. A part relates to the fact that they may not have the greatest endothelium on them, and perhaps are thrombogenic till they actually degrade completely and resorb completely. And perhaps this contribution of dual antiplatelet therapy for a longer duration. And by the way, we've applied it anyway much earlier on based on the TCTAP study. We've almost felt that most of our patients who had low bleeding risk should go on to it anywhere in our real world practice with the metallic drug-eluting stents, and therefore why not do it with this thick strut device anyway?
Yeah.
So 70% of our patients are being maintained on DAPT anyway over our experience over the last 3 years, and I think that is now coming into
it's
a
interesting
reality.
that we've had, and again, there's been a sort of a revolt against long-term DAPT, and some people say, well, it increases. You look at the DAPT trial. Yes, there was a reduction in stent thrombosis, but there was excess mortality. There's concerns about bleeding with that, and now we have a device that is kind of, we feel almost obligatory that we have to give 2 or 3
and
years.
the interesting part is that the device came in so that we perhaps could shorten the dual antiplatelet therapy at some stage.
Well, shorten it from lifetime, I guess. Alan, what's your take on the data and your practice, perhaps before we saw these concerns? Were you using this much?
I think I want to give you a perspective of sort of the U.S. standpoint, and also maybe from the sort of the regular interventionalist, right? Because I think we are all experts. We know the data. We've been using this device from the very beginning and trying to understand all its limitation. But if you look at the original 3 R's for absorb, is like to revascularize and to basically restore and to resorb in a benign way. I think we are kind of falling apart in all 3 of them, right? Because clearly revascularization, if you look at acute results, they are not as good. Always, whether it's acute gain, whether it's the measurement of MLD. And then when you look at the ability to restore, whether it is angina, whether it is the vasoactive, vasomotion function, as you know, has always been kind of tricky anyway. We don't have anything there. And finally, when you have reabsorption, you have all these data coming through, whether it is the ACC data, whether it's the AIDA data, whether it's the FDA. The regular interventionalist, I think in the U.S. basically has pulled back, and it's shown in the market. In the market, basically in the U.S. has, I would say, much less than a couple percent penetration, and it's mainly in the centers that are doing the trials. They absorb 4 trials, which has been, obviously stopped as well because they have, enough numbers. So I think there's a little bit of a concern in the whole community. We can say what we want, but the real sort of where the rubber meets the road, it really has been a problem, I think, for most of the interventionalists to spend the time to do the procedure and really not revascularizing as well. If you look at all the data, the TLF rate, TVF rate is all a bit higher. And certainly you don't get anything out of it in restoration. And the reabsorption, I think, has to do with either technique or technology. Is this technology, when it reabsorbs, is it benign?
Yeah.
I think that's really the crux of the matter. I think we can conquer the acute result problem by PSP. And I just with it, Adnan, with Ashok as well, is the technology have any tail to this?
Well,
After 3 years, it is benign absorption. I think we are then pretty good. But it is not a benign absorption, especially if the strut is just a little bit not touching the wall, just a little bit, not talking about hanging in the lumen, and causes thrombosis. Just need a few percent because our stents are so good now, right?
Yeah.
Our baseline of stent at 5 years is 2%, 1% in the first year, which a lot of it is acute procedure, and then for next 4 years,
Tiny little
another percent.
Yeah.
How do you beat that? It's pretty hard. And any little error or any little things that during the procedure, if it leads to stent thrombosis later on, is troublesome. So I think it's really, that's the part that, what do we gain from doing this for the long run?
I think you've hit sort of one of the nails on the head there, which is the story, the pitch, if you will, of this device. For a while, it was okay. Well, it's going to resorb over 2 years, and then you're going to get this benefit at 2 to 5 years or something like that. Now it's pushed further down the road. It's going to take 3 years to resorb, and we're not going to really see the benefits for 5 to 10 years. That's a long time for these folks. I mean,
for interventional cardiologists, we're not good at delayed gratification.
No.
So we're putting the stent, and we say, look, 10 years later, you're going to get some benefit.
Maybe.
It's hard. It's hard.
I agree with everything which has been said, apart from one aspect, that I would say that in its present iteration, that the device is probably not good enough. We don't want to throw the baby with the bathwater. Clearly, this is a revolutionary technology. If it was safe and if it was certainly effective, if it becomes safe, then it's truly transformational.
It could be, yeah.
But I think what we truly need at this time, like never other, till the time we have prospective trials on these very issues that we're talking about, does PSP really change the safety of this device, or perhaps the new gen device, till the fact that we understand, is it dual antiplatelet therapy? Is it going to do more harm, prolonged dual antiplatelet therapy, than good for this device? Till we don't have answers, we really have to be extremely cautious, perhaps use it in simpler cases who are younger, and perhaps the ones who I believe that should really have it even at this stage is the ones with multiple multiple stents being implanted, the full metal jacket. I don't like that year after year after year. Even if I see them patent at 4 or 5 years, I still feel that I worry for every year that goes on with this full metal jackets. And perhaps this is still the technology. If we use it judiciously, if we use our PSP, if we use our OCTs and IVUS measures, we can actually make it safe, especially for those younger group of people who actually have these multiple stents being implanted at very early in life. Having said that, I think the next step is clearly that this device has to improve in itself, and it has to become a thinner strut device. And thinner struts clearly can be one of the major steps ahead, because that's been clearly shown even by the histopathologists to say there's less inflammation in sets, their endothelia is better. Perhaps one major step forward would be a thinner strut.
Right. And that's under development both by Absorb as well as Elixir. I mean, there are several that are coming, and I understand at EuroPCR in a few, in a month or so, there's going to be a number of other devices presented. You were going to add something, Alan? Did you?
No, I was just saying that with iteration of this technology, it's a little bit different from DES, right? DES, before we look at, the acute,
Late loss.
gain and late loss, bang, we have IVUS, take a look, and you have a new stent pretty much. But here, how long in iteration do we think we need? Let's say there's a Gen 2 of absorb. And how long do we need to look at this to say, well, this is actually has solved the problem? I would say at least a couple of years, if not more, right? So the cycle becomes a little long, a little expensive. So it is a daunting, but obviously very exciting, but at the same time daunting task to get a second generation to prove it is better.
I think it's, I also have always, thought myself this, the concept of PSP makes sense and using adjunctive imaging and all those sorts of things. But one of the real miracles to me of the current generation drug-eluting stents is how forgiving they are. And what we have here is a device that is not nearly so forgiving. It's more demanding of the operator, it's more demanding of the patient. And there's something about forgiving devices that are successful in our field. They can, you can skip a step. You can not perfectly post-dilate it. You can, not size it actually, optimally exactly right the first time.
You're right.
Our devices we have now accommodate most of those things very, very nicely.
And that's why that's the reason why with the metallic stents we see good results even in pretty shoddy hands.
Right, but not everybody is, is perfect.
Correct.
Not everybody's having a perfect day every day, and so there's advantages to having devices that are flexible and forgiving, and I think that we shouldn't forget that.
In fact, that's the reason why I so strongly believe that BRS is not going to replace metallic discs, because of the fact that if it's only safe in a few hands, and if it's
Then who can use it?
unsafe
Right.
for most, then who can actually use it?
Yeah, exactly. Adnan?
David, it's a great target to pursue for sure, and I think there are three issues to resolve. One, what to do with patients who are getting these devices in the settings of studies, of registries, because they are running and they are very important to be run. Second, what to do with patients who have got these devices. And third, how to go on with iterations. Because I think we should go back to the basis, to the preclinical studies, just to identify the characteristics that may increase the chances not to have these problems. So for those patients who have got these devices, is the length of therapy for sure. For the new iterations, we should know what kind of preclinical characteristics are predicting good results for the next iterations. But I have to warn you, for example, the role of strut thickness was not identified in preclinical studies. Was only identified
In thousands of patients.
In patients, in clinical. So it's not an easy thing. Just thin struts is a good idea. It's everyone is thinking about it, but it should be shown that thin struts in preclinical are having better results than thick struts.
I think that's fair.
I think we're going to have to rely a lot more, go back to the preclinical data, because just like Alan pointed out, we can't actually wait for every iteration to be tested out, not just 2 years, perhaps for 5 years and 7 years.
We'll never get there.
We actually talk about accepting it as a routine part of our clinical practice. On the other hand, now that histopathologists who actually did the study going back onto it, they're even far more interested in predicting this very issue because it's become the talk of the whole talk. So I was speaking to one of the experts who'd actually looked into this, Ashok, and again, he's looked back and he's gone back to everything, and of course he's come up with this thought process, perhaps that the thinner struts would actually have a lesser inflammatory response, and perhaps the endothelialization. In fact, it's the nature and quality of the endothelialization. So everything we talk about,
all the problems
thrombosis, late thrombosis, just related to the thing collapsing and dismantling, may not be the only issue that there exists in it, or could be just the quality of the endothelium which is on it, the inflammatory responses on the endothelium, which may actually also predispose to scaffold thrombosis or late scaffold thrombosis.
So let's, you have something you want to add, Alan?
I was saying that it's, the promise of the, bioresorbable scaffold is that, let's say nothing happens in second to fifth year.
Okay.
And you end up with a golden tube.
Right,
as,
Patrick's
talk about it. The implication is that that layer of endothelium is somewhat protective than a regular layer of endothelium, which has actually never been even tested talked about in any way, meaning there's no magic carpet there
Yeah.
that somehow can
paving
prevent
the
you from
vessel,
atherosclerosis. Not talking about anything related to the scaffold. So if that's not the case, obviously the patient level events are still very high,
Yep.
as compared to in other events show. So I don't know what we're chasing. Sometimes we end up chasing something maybe it's not really achievable.
Well, it is this interesting, until bioresorbable scaffolds came along, my patients weren't complaining about these scaffolds left in them. Now, of course, there are the small percentage of patients in whom, they have recurrent refractory restenosis, and we wish that what was in there we could dissolve away for that. But the vast majority of them do pretty well, and it's, I actually had the opportunity, I just cathed a patient last week, one of the very first patients that I cathed, she had a BVS placed at another center a couple of months ago and just was in with atypical chest pain, and I started explaining to her and she said, why would I want it to go away? How is it going to do this? It was a very interesting discussion, and we talked about those things. Let's just finish up with just thinking about, let's say we actually had a device we trusted that did what a BVS is supposed to do. It was, thinner strut, no major excess of thrombosis or anything like that, a little harder to work with. Who are the patients we want to put this in? You already weighed in a little bit on this, Ashok, so let me ask the others first. Alan, who needs a BVS?
So your premise is that there is no difference in acute and medium-term
Let's hope.
events.
Yeah.
Let's say, then I think, device like this either should be sort of your workhorse or really not in existence almost.
So if it can't be a workhorse, it's not.
What are we buying in a sense?
Yeah.
I think if you can actually be as good as our current generation of DES, then obviously I would like to replace everything with it because it gives you the promised land that indeed is not there, and you have a chance to lower the cholesterol, get the LDL down to 30, and therefore no more atherosclerosis. So I think I would say that
workhorse or nothing.
Workhorse or a very small subset, because I'm not sure exactly what I'm trying to create in that small subset of people. Obviously, there's technical limitation, calcification, all the other stuff. But if you sort of say, well, it is no different from what we have in our current generation.
That's pie in the sky a little bit. I mean, to get there. Adnan, what do you think?
You're going
to go the other way?
I must defer, yeah.
Oh, okay.
I'll put it up there, right?
And I would say that if we solved all these issues, especially this late scaffold thrombosis
Which
issues,
is a big issue.
Which is a big issue. It was, before that I wasn't even concerned about what was happening, and you mastered the technique, and you sort of, there was a learning curve to doing complex cases, and I can still go all the way to 3 years and have these complex cases with 2 scaffold bifurcations, which I'm going to be presenting again, and which is doing fine. But the real issue in my mind is that if it all were equal, and it was only the learning curve issue and the fact that you deployed them differently, I'm all for actually extending it to nearly 50% of my patients, going to 70% of my patients, because not having a metal, I know it's a golden pot at the end of a rainbow, but perhaps it's the golden pot to go for because it's just intuitively the right thing. Why should we have a metal implant in our body for the rest of our lives? We've known that it's a problem, and we have patients who've had problems with that metal implant. So that is my real issue, that if it was if it was that good, I'd go for it. And I'll make it happen. Like you said,
that's what Alan said too. I think he said.
I'd say I would make it the workhorse. I'll make it happen as the workhorse. It doesn't have to be like a metal stent.
Perfectly easy. But it would be worth it. Adnan, what do you think?
It's the same. So if all things equal, I would prefer BRS for sure. Depending on how much I should invest, I should invest for doing the procedure.
Okay, all right. Well, that is fair. That's my work to figure out if we could actually afford any of this, and we are actively doing that. Although I think again some of the hypotheses have changed. Well, I think our time is up. We're actually a few minutes over. A talkative panel, which was great. And again, I really do want to thank everyone: Alan Yeung, Ashok Seth, Adnan Kastrati, and myself, David Cohen, and all the organizers for inviting us here. I hope you have a great meeting.